I'm going to be chairing the symposium, and just before introducing our speakers, I want to just provide a bit of background and rationale for this topic. And so this graph shows OECD countries that are primarily rich countries, ranked according to average life expectancy. And this ranking has been called the Health Olympics. And as you can see, Japan wins the gold medal in this competition and has an average life expectancy of close to 82 years. So how does the United States do in these Health Olympics? Well, it's tied for dead last with an average life expectancy of close to 78 years. And so we see this gap of around 4 years between the US and Japan, which is a substantial gap at the population level. And this is despite the fact that the US spends 2 to 3 times what Japan does on a per capita basis on healthcare. There's this notion of upstream root causes of health called the social determinants of health that may explain why we see these wide variations in life expectancy across countries outside of healthcare. And this is a conceptual diagram on the social determinants of health that I've adapted from the WHO. And this shows the social determinants of health in the upper half of the slide that act through intermediary determinants, including health behaviors, biological factors, and psychosocial factors at the individual level that influence health and disease. And so the social determinants of health are the material, living and working conditions and social environmental conditions, and the structural drivers of these conditions, which include socioeconomic status at an individual and area level, race, ethnicity, and gender. And then at the very top, we have these broad macroeconomic, social, political, and cultural factors that are at the societal level. And these are what stratify people into different social groups, including higher and lower socioeconomic groups, dominant racial, ethnic, and gender groups, and higher and lower social capital groups. So this is a conceptual diagram of the traditional link between epidemiology and policy. And the traditional role of epidemiology has been to test scientific hypotheses on causal relationships of exposures and health outcomes, the results of which should be synthesized and lead to policy evidence-based recommendations in the formation of policy. But the messy truth is that the path from epidemiology to policy is often not this perfectly rational, linear one, and the choices of which hypotheses are pursued and how they are translated into policies doesn't occur systematically. So there are 2 questions. One is, what is it that determines the first step? And second, what are the drivers and incentives that move us from step 1 to step 5? So why should we have a policy-relevant epidemiology? So as you saw with the Health Olympics and measures of health disparities, evidence on that, they point to the need to improve population health and reduce health inequities. And through adopting a social determinants of health lens and approach, we can move in this direction and achieve the greatest good for the greatest number. But there have been a limited number of studies on social policies and programs that address the social determinants of health. In addition, there have been recently calls for an epidemiology that's consequential. That is an epidemiology that's more directly linked to interventions and policies. But there's been a lack of systemic drivers and incentives for epidemiologists to bridge this epidemiology policy divide. So we have 3 speakers today, and Catherine Thial will be our first speaker. Dr. Thial is an associate professor in Tulane University School of Public Health and Tropical Medicine's Department of Global Community Health and Behavioral Sciences. She's also director of the Mary Amelia Douglas Whitehead Community Women's Health Education Center. As a social epidemiologist, Dr. Thial's research focuses on policy and community influences on health disparities, with a particular emphasis on women and children's health. In addition to national and total and local observational research, she's actively involved in local interventions and policies aimed at altering environments for better health in vulnerable populations. Kelly Comroe will be our second speaker. Dr. Comroe is professor at the Emory University Rollins School of Public Health in the Department of Behavioral Sciences and Health Education with a joint appointment in the Department of Epidemiology. She's a social and behavioral epidemiologist with 2 decades of experience leading NIH-funded group randomized trials, evaluating effects of community interventions to promote child and adolescent health. She's currently leading a National Institute on Minority Health and Health Disparities funded study to investigate state-level family and economic security policy effects on infant and child mortality. And I'll be the final speaker. I'm an associate professor in the Bouvet College of Health Sciences at Northeastern University in Boston. I'm also a social epidemiologist, and my research focuses on the social and economic determinants of population health, with a particular interest methodologically on strengthening causal inference and applying microsimulation models for social policies. I'm also founder of the International Social Epidemiology Society and principal investigator of a new R1 on the social determinants of cardiovascular diseases, for which I'm actually currently looking for a postdoc. So if any of you are interested or know of someone, please feel free to speak to me afterwards or contact me. So all 3 of us will be giving some concrete examples of our work that I think help to address the epidemiology policy divide from a social determinants of health perspective. And then after all of us have spoken, we'll have a combined Q&A session for the final 10 to 15 minutes. So please hold your questions for the panel until then. So I'll turn things over now to Dr. Leon.
Pretty loud to begin with, so I'll place it a little bit lower. Okay, so welcome, good morning. I'm really excited to be here. Can you hear me okay? Okay. I am, like Daniel said, I'm a social epidemiologist in a behavioral health science department, but it's very fitting for my work, both practical and didactic, and I love coming to ACE because it really keeps me connected to the field, even though I'm not in the epi department. We do a lot of epi, but we can't call it epi. So what I'm going to talk to you today is social determinants of health and health equity, and how we might use these to really close the gap on health disparities from a maternal child health perspective. I came into this work, I'm fairly new to the policy arena. I've done a lot of neighborhoods and interventions, both for social network and individual level interventions, and it really led me to hit me on the head. Kelly and I were talking about this, that we've got to look beyond the individual and interpersonal to really make a difference. And so that's led me to the policy arena, and directing the Women's Center has allowed me to do a little bit more of that. You all have probably had many welcomes. I'm going to give you another to our great city. I hope you have enjoyed your time in New Orleans. And with the short time I have, what I want to do is talk a bit about health equity to make sure we're all on the same page, and then give you some of our policy examples. Mostly descriptive, we've got some analytic work, but I want to talk about our experience with policy translation and give you some examples of social context as well, and how that might relate to health disparities. And then I'll talk about some challenges and future directions, and I think we'll all do that together as well. Before I begin, I want to thank my colleagues and stakeholders, particularly Dr. Meg Wallace, who has played a big role in some of the work I'll be presenting today, as well as Dr. Phyllis Roth, who's a sociologist at Tulane and has really been instrumental in schooling me on advocacy, and together have worked on quite a bit. A lot of the work I'll be talking about today has been funded by the Kellogg Foundation and other stakeholders, but mostly Kellogg. So what do we mean by equity? I'm sure you've all heard of equity, right? Yeah. There are many definitions. I like the National Academy of Sciences presented here, which is the state in which everyone has a chance to attain their full potential and no one is disadvantaged from achieving the potential because of social position or any other defined circumstance. We can also, of course, flip this, no one should be advantaged either. And equity is, of course, linked with opportunity and necessary to reduce health disparities. Equity differs from equality, as most of you know, and this little depiction is from our City of New Orleans Equity Report. And on your right-hand side, you see a picture of equality. So all of these individuals are given the same size box to catch their Mardi Gras beans that are local parades. Whereas for equity, oops, so sorry. For equity, people are given just what they need in terms of the size of their box to reach their full bee catching potential. And so there is a difference, and I want you to keep that in mind as we move along too. Equity and the social determinants of equity are what Tamara Jones refers to as sort of the third level of health interventions. And again, it's really key when we start thinking about how to move the needle in health disparities. And so what you see here is Tamara Jones's sort of cliff analogy is what she calls this, where there are 3 levels of health intervention. The first being the ambulance and the safety net and the fence that keep people from falling off the cliff, catching them before they hit the bottom, and then of course the ambulance that will take them over to safety and save their lives should they fall off the cliff. Level 2 is social determinants of health and sort of addressing those determinants to move people further away from the cliff and keep them from falling off. Whereas level 3 are addressing the social determinants of equity, things like racism, classism, sexism, the things that are most difficult to address, but which are needed to really move the needle. This is an example of sort of the differential distribution of certain social determinants of health that of course lead to differential impact or health disparities. We use this conceptual model in a lot of our work with children's health to kind of couch this in a sociological framework, using Grothendieter's socio-ecological context and how various contexts might produce negative health outcomes and disparities in health outcomes. And this is a pretty simplified model, of course, looking at state-level factors that can influence local, and then individual and interpersonal level factors that all play a role in shaping health. And what we know now is that individual and interpersonal are not enough. We really have to look beyond to neighborhood, which is where a lot of our work has been concentrated, but also to state and larger macro policies, as Daniel mentioned. Because while we've made some improvement, again, not just for children, women and children's health, but in other health outcomes as well, we still have large disparities. Black infants die at twice the rate of white infants in this country. Black women, maternal mortality is 5 times the rate of white maternal mortality. Breastfeeding rates are lower. I can go on and on with a number of health conditions that you're probably aware of. So we still have quite a ways to go. And so what I want to talk to you today about is some examples of 3 policy level factors we've looked at, of paid leave, reproductive rights, and breastfeeding support, but you can think of many others that might impact maternal health. I also want to talk about some social contexts, which are shaped by historical and contemporary policies, things like structural racism that might play a role in shaping health disparities. And of course, there are many other contexts as well. Wage gaps, sex, race, ethnic representation. We can go on with these lists, but again, these are important to think about. So starting with paid maternal leave, our picture is pretty grim here in the U.S. We're actually, the U.S. is now one of only 2 countries without paid maternal leave. The other is now Papua New Guinea. All industrialized nations have maternal leave. Most have up to 14 weeks of paid leave for mothers and infants, and there are additional parental leaves as well. But here in the U.S., women are 47% of the U.S. workforce, half are primary breadwinners, and 64% with children under age 6 are working. And so there's a great need for leave, as we know. And certain states have passed legislation. This number keeps growing. I think at count today we have 4 states, California, Rhode Island, New Jersey, and New York, and DC, which all have paid leave. Certain jurisdictions as well, even here in New Orleans, our city of New Orleans has passed leave. So there is movement, but we have a long way to go. And of course, paid leave has implications for family health, as well as long-term health and development, and it really speaks to what we value as a society and how that must really change. From a business case, leave has been shown to lower healthcare costs, increase employee retention, morale, productivity, so there's a business case for paid leave policy too. Here in the U.S., 88% of women have no access to paid leave, and only 40% of women are covered under our Federal Medical Leave Act of 1993, given that there are restrictions to that act. You have to have been employed for 12 months, you have to be working in a company with 50 or more employees who live within 75 miles of the company, and there are other restrictions as well. So only 40% are covered under FMLA, and FMLA only protects your job. So it doesn't necessarily come with paid leave. And normally, for maternity care, women and fathers are scrambling to have some kind of a coverage and time off of their child. 23% of new working mothers will be back on the job within 2 weeks. And of course, this has been shown to have major health implications for the mother, increased anxiety, depression, and suicide, but also for the child. There's been shown to decrease breastfeeding and immunization. I could go on and on. So we took this on in 2005 to look at our situation here in Louisiana and what we were doing with respect to paid, not only family leave, but sick leave as well. And so, of course, not surprising, Louisiana was one of the worst states for leave policy, but what we really found is that, like most states, leave was differentially distributed. So, as shown in this figure from the paper, figure 2, it's hard for you all to see, but 70% of women who made less than $15,000 a year lacked paid leave and sick days versus only 20% of women making $65,000 or above annually. So access is differential for sure. And we took 2 approaches to our advocacy and communication strategy. And one was, giving a lot of talks, a lot of policy brief creation. We had Heidi Hartman, who runs the Institute for Women's Health Policy Research, come and do a lot of local talks. We also worked with a state senator, Karen Carter-Peterson, on 2 Senate bills, one for paid leave and one for sick leave, that were based on an insurance program and for companies with employees of only a minimum of 10 employees, so trying to give a bit more access. And there was also a House bill as well. These were all killed in the session, but we continue to work on pushing the needle from an evidence perspective. This is an example of one of our policy briefs that we've created, again looking at paid family and medical leave in this case. The audience was pretty broad, so what we did was try to paint a picture of the benefits, health, some business, but I'll kind of mention this later. I think we could have done a better case in making the business case for paid leave because, frankly, businesses and employers, they care about health, but they care more about the business case. So, lesson learned on this front. And then what we did was try to give them options if they were an employer, things that they could do, if they were an individual, things that they could do as well. So a pretty broad policy brief, which we're tweaking now to be a bit more targeted in our work. But an interesting venture. We've also worked with businesses on breastfeeding policy, and this is some of the work supported by Kellogg, looking at helping businesses implement policy and space for lactation support for mothers. So we provide breast pumps, we help them build out a room within the company, and we also wanted to look at the awareness of the Nursing Mothers Law, which was part of the Affordable Care Act, and that passage of the ACA in 2010 required businesses with 50 or more employees to provide women for up to 12 months break time, reasonable break time for lactation, and a space, not a bathroom, to breastfeed, as well as storage. And so we conducted a random sample survey of New Orleans employers with 50 or more employees in the fall of 2013, just to get a sense of where they were with awareness. And 48% reported hearing about the law. They were more likely to be larger businesses. 53% were actually implementing some type of support. Many of them hadn't even heard about the ACA, but they were still supporting women anyway. And some of the barriers that employers mentioned were the lack or limited number of female employees, the lack of space within the company. And then in fall of 2015, we did a follow-up sample, and luckily we have seen an increase. So about 67%, at least in fall of 2015, have reported hearing about the law, and 75% are implementing. But this is great, but this is only about employers with 50 or more women, right? So we're missing a large chunk of our workforce. The service industry in New Orleans, as Dr. B mentioned, is a huge component. And so what we're trying to do now is really target companies and employers who don't have these benefits, right? One more example at the policy level is reproductive rights. We know that they matter, and of course, in our political climate, these are ever changing. But what we did here was look at a reproductive rights index based on 2011 data for every state in the U.S., and this is from the Guttmacher Institute, and we looked at policies related to mandatory sex education, expanded Medicaid family planning, mandatory parental consent notification, mandatory waiting periods, public funds for abortion coverage, and the proportion of women in counties without an abortion provider. And we created an index that ranged from 0.23, a low in South Dakota, to 4.78, high in Oregon, and looked at its association with adverse birth outcomes. And what we found crudely is that the rates of low birth weight, preterm birth, and infant mortality were lowest in states with higher reproductive rights, or the highest tertile of the reproductive rights index. And that held up for preterm birth in adjusted models. So a 1 unit increase in reproductive rights index equated to about a 4% reduction in preterm birth. When we looked at that within each indicator separately, we saw that in states with expanded Medicaid family planning, we saw a reduction or a lower likelihood of low birth weight. And for states that had mandatory parental consent notification, we saw increased likelihoods of both preterm birth and low birth weight for women in those states. And for states with public funds for abortion coverage, again, we saw lower likelihoods of these outcomes. And then for states with counties that had a greater proportion of women with an abortion provider, saw a lower likelihood of preterm birth within those states. So what about social determinants, other things that might matter and play a role in maternal-child health? Many have looked at income and wealth. We know that they play key roles, but they also differ significantly by race and ethnicity. And unfortunately, we're getting worse. In the U.S., this graph to your right shows the white to black wealth inequality that's grown since 2007. So you can see, it's hard to see in 2013, we've got a ratio of white to black